Good afternoon, everyone, and welcome to this week's EPICENTER Psychosis Speaker Series. Glad that you all can join us this Friday afternoon if you're here on the East Coast, or maybe earlier in the day if you're on the West Coast. Today, I'm delighted to introduce our speaker, Dr. Nev Jones. Dr. Nev Jones is an assistant professor in the Department of Psychiatry at the University of South Florida. And I'm sure for many of us who are on the call is one of the real international leaders in improving and investigating service utilization, especially among individuals early in the course of a psychotic disorder, where much of her research to date has focused on highlighting the importance and working to really break down systematic barriers to the delivery of peer support as a key component within specialized care for individuals with serious mental illness. And today we're going to be lucky enough to get to hear about some of that research and work that she's done in ways that will hopefully help us all with expanding our ability to make this part of our usual care. So with that, I'm delighted to turn things over to our distinguished speaker today, Dr. Nev Jones.
Thank you. All right, and I am just going to, oh, there we go. Share my screen. But it's great to be here. Let's see. Okay. And so I think the idea is that people can just, just add questions, comments into the chat as we go. I do want to say that when it comes to kind of peer support, both in early psychosis settings and more broadly, I have worn many different hats, but this is actually a pretty research-focused presentation. So I'm happy to talk more about kind of implementation experiences, program development work in the Q&A, but I'm not really gonna integrate any of that in a direct sense in the presentation. I'm also I've been the peer kind of training module developer and peer co-trainer for the National CSC on Demand trial, which has really been a very interesting experience in that many of the programs that we're training have now already been in operation for a while. So the peer specialists have often been working for, anything from a few months to a couple of years. And it kind of has enabled a lot of contact with people in programs following different models in all different parts of the country. Really, really interesting kind of learning through those interactions about what's going on in the sometimes very different forms that these peer roles have taken in different parts of the country. But again, that's not a research project, or at least not in my training capacity. So So I wanted to first just kind of quickly acknowledge some collaborators. This is really specific to the actual CSC peer support data that I'll be presenting. So essentially kind of Lisa Dixon's team at the New York State Psychiatric Institute and kind of On Track Central. And then Youth Move Success for Kids and Families, Healthy Minds. So the early psychosis and also healthy transitions program in Tampa, and some of the interviews I'll be drawing on were all conducted by youth who are themselves youth peer specialists associated with Youth Move Tampa. So goals for the presentation. So as will become clear as I kind of walk through some of the literature, there are a lot of unanswered questions about effectiveness, underlying mechanisms, and implementation when it comes to peer support, both in general, but especially really in kind of real world public sector mental health settings, and with respect to coordinated specialty care, kind of specialized early psychosis programs. And so, kind of given the nascent state of things, the number of unanswered questions, I think goals would be for you all to maybe kind of think as we work through the material about the sort of more macro context. And I'm going to start with some kind of history and policy, because I think there are still unanswered questions, even at this more macro level, about future directions for peer support in the United States and more broadly lived experience roles. Just being sure to to keep in mind this distinction between what we know, which sometimes is pretty inconclusive, like with respect to the effectiveness of peer support, versus the potential for what we could learn and the potential really for peer support roles in, again, mental health services in general, but also early psychosis settings specifically, and the potential impact that could be had. And that's not necessarily that we've already figured it out, but kind of where this could go. And then what might matter most in the specific context of coordinated specialty care, because there has been a lot of research on peer support, and peer roles are now common in just about every setting that you can think of, whether it's physical health, integrated care, homeless outreach services, obviously substance use, primary mental health, the children's system, adult system. So kind of everywhere you go, you see different kind of versions and iterations. Criminal justice, jails, some jails are starting to integrate peer support, and then certainly jail diversion programs. So just thinking about kind of what matters most in this early psychosis setting, what has the most potential. So historical context. So really, when we think about kind of the contemporary peer service user movement, really got started in really the 70s. But you already start to see some organizing happening in the late 60s. And this is in the context of the women's movement, Black rights and Black power, Farm Workers United, the beginnings of the independent living physical disability movement, which in some ways gained steam more quickly than sort of peer service user organizing. But, so definitely in this context of kind of social movements, social change oriented towards rights and social justice, a lot of the advocates originally involved, advocates and activists, right, had been experienced periods of institutionalization. And so while kind of released in the context of broader efforts around deinstitutionalization, that was really sort of the backdrop of their experiences and a lot of the context for the kinds of changes that they were pushing for. But as with these other movements, there was also a big focus on kind of consciousness raising or conscientization. So increasing the awareness of people who, especially maybe in and through long-term institutionalization, had maybe kind of really become engulfed in this patient role in a way that maybe more kind of profoundly affected their identities, and sort of trying to really empower that community of people and kind of remind them of rights discourse. As we move to the 80s and 90s, as you all are probably well aware, right, 1981 saw the repeal of the Community Mental Health Systems Act. So all the money, relatively large amounts of money at the federal level that were sort of slated to go to creating this vast network of community mental health centers was massively scaled back. And then simultaneously, we see sort of, right, the era of the war on drugs. And there's been some, really great kind of health policy analyses that have looked at how the war on drugs kind of tended overall to divert federal money that would otherwise have gone to mental health services to the prison system to support the prison system. And then this kind of real criminalization of substance users through, ramped up drug trafficking laws, minimum sentencing, et cetera. And also really just kind of shifting societal discourse from social context, right, and sort of substance users as, as kind of people who have maybe experienced trauma, stress, hardships that we need to support, to really this it's their individual responsibility. They have sort of entered into these addictions, and then sort of tying that to sort of trafficking and illegal drug use and being diverted into the prison system. There was kind of a civil rights affirmative action backlash in general. See that even vis-a-vis the women's movement. And at the same time, some gains in disability rights. So the Mental Illness Bill of Rights Act of 1985, which really kind of led to the to sort of the PAMI system, right? So sort of legal supports for people with psychiatric disabilities, the Fair Housing Amendments Act of 1988, which targeted housing discrimination. And we start to see the initial integration of peer staff in community mental health centers, not yet in a formalized way, maybe late 90s, right? But then as we move into the 2000s, first, we really see kind of a huge diversification and maybe even kind of fragmentation of the movement. And so for one thing, people are coming, are receiving services of different kinds for a whole host of different reasons. This can include anything from being prescribed an antidepressant from a GP or a primary care provider to, long-term involuntary hospitalization, somebody who still ends up in the state hospital system, mostly probably kind of a forensic situation. So really huge differences in how people are experiencing mental health services and the sort of the nature of those experiences. And I think this leads to just kind of a fragmentation and proliferation of kind of policy agendas of issues that different people have, different people in different groups have been concerned about. And, a number of people, obviously, who move into advocacy activist roles who haven't been certainly institutionalized long-term, and in many cases never hospitalized at all. There's kind of been complex intersections with the disability rights movement. They've never really come together, which is not true all over the world. There's some places where sort of really the disability rights umbrella really more kind of fully encompasses what we would think of as mental health issues here. Then in 2001, Georgia and Arizona became the first two states to employ certified peer specialists through Medicaid, through a Medicaid waiver. And as of 2017, so Jessica Wolf and I did a project just surveying state certifying entities. All but a handful of states had Medicaid waivers in place. And those Medicaid waivers generally require some sort of certification process. California, just as of yesterday, the governor signed a bill to implement a certification process in California. And California is really the last kind of big holdout state. And so there has been a huge expansion of the workforce in the last 20 years. And, I think more recently, we've also seen efforts to expand peer support in kind of private pay settings, in, hospitals and clinics that are not necessarily primarily billing Medicaid or serving a Medicaid population. And that's some of the impetus behind the National Advanced Peer Support Certificate that Mental Health America kind of developed in the last 5 years. And then I think especially with COVID, we now see a huge emphasis on digital peer support, digital kind of iterations of telehealth, mHealth, eHealth, and this is likely to just, explode kind of from here on moving forward. So let's see. So I want to say that, so sort of, one narrative that we could tell here, right, is that in terms of public mental health services in the United States, we see, we see the backdrop of the movement, the kind of work, the push for alternatives, the push for sort of nothing about us without us that was happening in the 70s and 80s. And that is sort of similar to what was happening in other kind of Western high-income countries, including the British Commonwealth, so Australia, Canada, the UK. But things have kind of gone in different directions. And so in the US, we see a lot of that, the energy and the push for sort of lived experience involvement being funneled into peer support, and then what I would call peer support leadership roles. So at the state level, if we look at divisions of consumer affairs, just for example, typically a major part of that individual's portfolio, and not every state has a director of consumer affairs, but most do, typically a major part of their purview, if not kind of their, you know, the lion's share is peer support services in their state, and then maybe to some extent kind of stakeholder involvement in policy. And then we have direct peer support workers. And the next level up from peer support workers is certainly peer supervisors, who themselves are have been peer supporters, have lived experience. However, if you look at, and the UK is probably the most well-developed example, but pretty parallel in Canada and Australia and New Zealand in a somewhat more nascent way. I think there's been a move more broadly to what's increasingly being referred to as lived experience professionals as kind of an umbrella term. And then under that, peer support roles and services, which don't necessarily look dissimilar to the kinds of peer support roles that we see in the US. But then service user educators in university and college settings. These are typically people with at least a master's degree. And these are dedicated roles. So it's not like we just happen to have somebody on staff who has lived experience. They're hired for that reason and to really make that central to the training of clinicians. It's probably, I would say, most common, or I've seen the most written about this in nursing settings. So in kind of the training of nurses. In the UK, there's mandated involvement in licensure and renewal. So for clinicians, seeking initial licensure and then renewal, they actually have to have part of their education has to have been provided by people with lived experience. You have service user researchers and research staff at both the master's and PhD level. And there, again, these are dedicated roles. So I think that's the big difference with the US. We have researchers with lived experience. We don't have dedicated roles. I've actually just never seen this in the US. And it also creates kind of an alternative. So each of these pockets, I guess I would say, are creating alternative career pathways for people with lived experience and formalized ways in which that lived experience can start to influence systems. And then lived experience systems design and quality improvement roles, which in the UK, the National Health Service created this sort of massive umbrella entity called Involve, which is really cross-cutting across all areas of health, but including mental health, to really build stakeholders into, kind of health services design, rollouts, quality improvement, and evaluation. So these are not in any intrinsic way tied right to peer support roles. It's a separate thing. It's really about the design and kind of accountability of systems. And again, they're like, many full-time dedicated roles. So I bring this up because sometimes I think it's helpful for us to sort of, just kind of get outside of our own box in terms of US context and think about other ways that this can play out, this sort of being, the role that people with lived experience can potentially play in systems. And I think as we discuss some of the challenges and limitations associated with peer support roles as they've been operationalized in the US, it can be helpful to keep this in mind as well. So turning to existing research, I really wanted to just kind of summarize this for you all relatively succinctly. In terms of findings from RCTs, so the sort of gold standard, the top of the kind of hierarchy of evidence, we know that sort of multiple RCTs have found no significant differences in the performance of case managers with and without lived experience. trends a little bit depending on the measure, one way or the other, but basically we don't really see any difference. So the idea is here is that a case manager with lived experience is not, kind of performing in, or providing a lesser service. There is pretty clear evidence supporting a handful of specific structured time-limited peer-led interventions. So RAP, Bridges, HARP, HOP are all some that have had at least one RCT, really kind of supporting positive outcomes. Sonia Johnson's team in the UK recently published initial findings from a trial of crisis team discharge navigators. This is in London with very, very positive results, and they're now doing a larger trial. But keeping in mind about these that they're generally short duration, and a limited kind of structured intervention. And so, as I will kind of repeat throughout the presentation, big difference between those kinds of interventions and peer support roles in kind of real world public sector settings. People are not just leading rap groups all day. There are overall, when we look at RCTs, so not just these specific, very structured, manualized interventions, but when we sort of look at everything together, basically conflicting or unclear findings, null findings, in a lot of the systematic reviews and meta-analyses over the past, kind of decade, poor quality has repeatedly been noted, conflicts of interest, and so the Cochrane review, which is probably the most recent, basically said that the sort of the evidence base is so mixed, but also so weak and lacking in rigor that we essentially can't come to any conclusion as to whether peer support is effective or not for people with SMI. Other recent systematic reviews have again sort of said there's basically really not true support for kind of widespread mandates around peer support given where the evidence is actually at. And I say that when I'm kind of presenting to groups of peer-run organizations and peer providers too, because I think it does not do anybody a favor to sort of not be aware of the sort of realities of where this research is at. And my hope is more that it sort of really galvanizes us to do better, to do more moving ahead. Where there's some empirical support, so now we're kind of moving out of RCTs to kind of pre-post survey projects, qualitative research, kind of observational research, ethnographies, case studies. Kind of specific to psychosis, there are a number of studies, again, with kind of methodology limitations that have looked at hearing voices groups and pretty consistently found positive impacts on kind of perceived meaning making meaning out of one's experiences, understanding connections. So the Hearing Voices movement really focuses on kind of connecting the content of voices to life events, empowerment and sense of community. In Australia, a group of clinical psychosis researchers at Swinburne University under the leadership of Neil Thomas worked with Voices Vic to create a structured intervention called Voice Exchange, which brings together intentional peer support and a Hearing Voices movement framework. And they've started piloting that. And then there's, kind of quite a bit of qualitative, observational, and kind of case study support for successive peer specialists reaching and engaging particular groups. So probably particularly prominent in the context of homelessness and then kind of criminal justice system involvement, formerly incarcerated folks, jail diversion settings. Although we maybe don't have the kind of evidence that normally rises to sort of the top of the hierarchy, in part because it's so challenging to kind of study these complex interventions, I think really kind of compelling reasons when we sort of look at underlying mechanisms behind the ways in which you can connect to people when you have also navigated the streets homeless yourself, and you know what it's like, and you know exactly what people are up against, and you know what hesitations they may have, etc. Then there's a kind of a workforce literature, right? So sort of what's the state of the US peer workforce? So Dana Fogelsong and I did a big project on kind of a big national survey to look at the state of peer supervision. And it is kind of, replete with a pretty large sample, 550 supervisors. Pretty consistent agreement that there's just a lack of standards of development around peer supervision, that the trainings a lot of people have received are not really adequate, that there's sort of ongoing role confusion, and also a lot of concerns about role implementation. And honestly, just sort of a lack of support for the peer supporters that they're supervising, and those kind of concerns about actually the quality of peer support implementation were consistent across supervisors who had lived experience, who had experience as peer supporters themselves, and those who didn't and were coming from a clinical background. So although it takes sort of different forms, you actually see pretty consistently concerns on both sides. Another project of ours looking at sort of the state of the field in terms of peer specialist working conditions and support for career advancement and mobility, found really wide variations across different types of settings, across different programs, but overall really a lack of support for career development and a perception that there really aren't opportunities for advancement, because you would almost need to move into a different role like social work, counseling, psychology, etc., because of the way in which our mental health system is very hierarchically structured and structured around formal education and licensure. And then low wages, consistent concern, again, among the supervisors. It was a huge concern among the peer specialists that we surveyed. And when we compare the wages of supervisors who themselves have a history of being peer supporters to supervisors without, it is an absolutely kind of staggeringly huge wage gap. Part of that is explained by education, because in many settings we essentially have divergent pathways to moving into a supervisory role. You do it because you're a licensed clinician, or you do it, because you have a history, have been working in a peer support role and are moving up, and that kind of promotion is possible. What we don't understand well. So to the extent that we do have kind of, right, a clear effectiveness literature when it comes to these more kind of structured time-limited interventions, we really don't know how that sort of translates to real-world settings in which, in fact, peer specialists are doing so many different things, and have these just really, really varied roles. We don't know kind of who, under what circumstances, benefits from what kinds of peer support at what intensity and duration. We actually just have almost no research that really in a direct sense helps elucidate this. We actually don't have consensus in the field, either among practitioners or researchers, around what actually makes a peer in a given setting, what critical ingredients might be, what aspects of identity or potentially shared identity or experiences are actually necessary or critical or beneficial. And again, we see this underdevelopment in the US of kind of research and also just programmatic and policy attention to the value and the contribution of other kinds of lived experience roles. In the UK, I probably could or should have added as well that the Division of Clinical Psychology within the British Psychological Association, for instance, just released a whole statement supporting clinicians with lived experience and their unique contribution to clinical services. So they are not in a peer support role, but it's sort of the integration of that lived experience with clinical work. Here in the US, of course, lots of clinicians have lived experience, but often they just don't talk about it. It's taboo, and it's not, there's no, again, like real underdevelopment of how we would integrate that into work in a sort of a recognized way. Hypothesized mechanisms, or I could have just said mechanisms, but with the caveat that most of these are really hypothesized. There's varying degrees of evidence to support some of these. So the way that Judith Cook and colleagues set up the sort of the trials of RAP that they did tested some of these, but sort of overall, it's, I would describe it as kind of relatively weak. But what has been sort of postulated in the literature is experiential knowledge, right? So that if you yourself learn how to manage or navigate distressing voices, you can help kind of guide somebody else through that process, or maybe it's more about kinds of systems. If you've gone through the process of applying for different kinds of welfare benefits, you can kind of share that knowledge, but also connection around it in a different way. The helper helpee principle, right? So that you're in a kind of a mutually empowering kind of dyadic relationship, social comparison. So, that the individual is kind of providing hope, inspiration, kind of proof that one can kind of come out the other side. And then demedicalization. So sort of this emphasis on living life well versus a more traditional clinical focus on symptom reduction. And then I think there's, again, like kind of unanswered questions. Some of this you could think of mechanism in some way, but I think unanswered questions about what are we really talking about when we say peer support or a peer specialist or a peer? What does peer actually mean? And I think different ways that we can think about this and think about the potential tensions here is, we can parse this in terms of a relational philosophy that's, for instance, about mutuality, mutual relationships, disclosure, and again, that being mutual disclosure of shared experiences. It could be about activities. So often the way that systems navigation roles are described, it's really about, being out there in the community, helping guide somebody through something, like taking them to doctor's appointments, filling out forms with them. And a lot of the navigation models actually come from cancer care, right? So it's like helping people get signed up for chemo and just navigate these complex hospital systems and bureaucracies. Could also be running a video game group, doing fun things, going on outdoor activities that in theory anybody could actually do, doesn't necessarily require lived experience. And then there's identity aspects, right? So is it about shared experience of mental health services, of, voice hearing in a, kind of the hearing voices group context, or recovery from distressing psychosis? Is it, having experience and connections to the broader movement of peers? Is it experiences of discrimination and devaluation? And I'm not saying these are mutually exclusive, but I think it's often not clear in settings. One of the complaints from our supervision survey is how often people might see somebody with only substance use experience working as a mental health peer, or vice versa. So as much as in this kind of ironic way, peer support is shaped around, ostensibly shared lived experience, we don't necessarily see that playing out in real world implementation. And when we really dig in, there's lots of complications. Okay. So just some initial implications for CSC, and then I am going to sort of present on some of our recent peer support research specific to CSC. But I think, again, thinking about this much bigger literature that's been around for a while, it raises questions about the who. With reference to CSC, does it matter if the peer specialists are young adults, individuals with experience of psychosis specifically in Australia? the peer specialists who work in the sort of the EPIC family early psychosis programs are virtually always have and are hired on the basis of experience in those specific programs, not just of psychosis. And then the sort of who in terms of those who benefit or potentially benefit, just like everything, right? There are people who just don't like therapy. It just doesn't work for them in any form, evidence-based therapy, alternative therapies. People who kind of primarily are interested in a medication route, like the opposite, right? So I think when we look at kind of a complex, really, really heterogeneous experience like psychosis, different things work for different people, and we just don't have a super great understanding of kind of who stands to benefit the most from peer support services and in what way. The what roles in the broader context of CSC. So again, I always tend to come back around to this, but service user, stakeholder involvement in planning, design, and policy, and education and training too. So if we move away just from, kind of the peer support role as a member of a CSC team, where are we seeing service user involvement at these higher levels? And could peer supporters play a role? Could they serve as a conduit? Could they help connect young people who are currently receiving services to these sort of opportunities to get more involved at higher or more macro levels? And then when we do look at individual programs, again, what are the activities or functions that matter the most? Is having, support groups really important? What kind of support groups? Are video game groups, in fact, more effective? There's just a lot that we don't know. And we see just a huge amount of variation, which is great. And there's a lot of creativity, but it's very this peer specialist tries that, and another one, might try something else. And I think it would be really helpful to start to generate some more systematic knowledge and learning. And then whether there is value or not, I think this is actually a completely open question, but around psychosis specific support. So something like the voice exchange would be one example. The whole intervention is, oriented to distressing voices very specifically, not generic mental health or physical health issues. Antipsychotic specific, because antipsychotics have a lot of side effects that other psychotropic medications don't. They are a continual kind of point of struggle for clients and service users. All the qualitative work that I do on, kind of clients' experiences of CSC medications come up again and again and again. And it is a major part of, I think, what it means for a young person to sort of navigate a diagnosis, the identity, implications for the future. Crisis focused, I think here we see a lot of certainty over where and when and how to involve peer specialists in the context of different kinds of crises. When somebody's feeling suicidal, acutely suicidal, needs to be hospitalized. Duration exposure. So you'll see from some of the data that I show from the On Track New York network that people don't necessarily consistently stay engaged with peer support over time, but that doesn't necessarily mean that they're not benefiting, and maybe even in profound ways, but it's a legitimate area for us to really kind of think about and dig into what it means to support high quality implementation. And this is maybe particularly challenging in the context of CSC, because almost always there's only one peer specialist on the team. Most of the time the team leader or their supervisor is not a peer. So I think it raises additional questions around, kind of what effective supervision, co-supervision, coaching, and sort of the involvement of somebody who is sort of an experienced, advanced peer supporter around kind of supporting individuals in their specific CSC program. And then there's a lot of scope still for innovation. So discharge and transition, because we've seen peer specialists be very effective in the context of hospital discharge? How about CSC discharged? Youth advocacy, so there's a whole world of kind of development in youth system, in children's systems of care and transition age youth programming around youth advocacy, which is different. It's sort of spun and framed differently to peer support. And then again, this sort of digital mHealth, eHealth space, which is maybe particularly salient when we're talking about young adults, youth and young adults receiving these services, because nowadays kids just grow up immersed, saturated in technology. And then briefly, okay, I just want to go through some of this data. Now, I had hoped that we would maybe be at a slightly later stage in terms of some of these studies that we're doing. But so this is sort of work in progress, doesn't yet answer anything. So this is On Track New York data, and the sort of question this slide addresses, right, is kind of how many clients meet with a peer specialist at least once in each quarter. So the way that data is tracked, once a quarter, the team leader has to fill out, did this client meet with a peer specialist at least once? So it could be that they met 20 times or just one time, and we can't make that distinction. But in terms of, kind of at 3 months, so these are the different kind of follow-up time periods along the bottom bar, it's 37.6%. And then you can kind of see that this percent shrinks, but this graph is also accounting for discharge or disengagement. So in the pink, so these are clients, or this is attrition. These are clients who are leaving the program. We always have to keep that in mind. And if you look at the little, kind of the wave patterns, right, you'll see that some of that 37.6% is indeed ending up in this discharge group. The dark green above that is censored, meaning they're still in the program and haven't reached that time point. We don't have data for them yet. And then the blue are kind of current clients. We have data, they're not engaging, or during that quarter did not engage or meet at all with the peer specialist. So I think the big picture here is kind of that we see, again, this is the On Track New York system with actually, very robust supports for implementation. I guess one could, imagine a world in which even more happened, but I think kind of pretty exemplary in terms of what the state has supported and the On Track Central team has developed. Relatively high rate of clients who see a peer specialist at least once, but that could just be an introduction meeting and then they never go back. So that's 61% of those who were otherwise, eligible in this data set, who over the course of the first year, saw a peer specialist at least once during each follow-up quarter, kind of dramatically goes down to 12.8%. So I think this starts to tell us something about penetration. Not everybody is meeting with a peer specialist even when they're consistently available. And there's a lot more to learn about kind of who are those people. It doesn't necessarily mean they're the only ones who would be helped. There may be other reasons why, certain groups or subgroups are just not, choosing not to engage or get involved, or will at a later point, like in their second year of services. So a lot of unanswered questions, but it's also, I think, starting to tell us, kind of something important. For the on-track data, we actually, the team leaders with the kind of input or the notes of their peer specialists actually have to summarize what is going on for each individual client. And so in our current kind of data set, we have 501 clients who have received peer support. That could be during one quarter, it could be 8 quarters, or more even. And so just coding by client to look at what they have received, close to 250, so close to half of them there's sort of been some primary form of targeted engagement work happening for, again, close to half individual support, one-on-one support, about 125. It's sort of documented that they've attended at least one group. For kind of social skills, social participation, where sort of the orientation of the contact or the interaction was around socializing. Again, about 120, I think. On-track naps is a somewhat rap-like, but also sort of alternative, kind of self-exploration and planning tool that Sasha DeBrule initially developed and is now widely implemented at On Track. So we see a lot of on-track naps work happening, community outings, again, just introducing people to the peer role, discussions of recovery, and then I think interestingly, art and photography. So again, depending on the peer specialists and their own talents and interests, you can kind of see some of this other stuff play out, some really interesting examples. And then school or work, kind of conversations, discussions, tackling family dynamics, relatively speaking, comes up a lot. Discussions of identity, and then kind of navigating medications. And this coding work is in progress, so this isn't comprehensive, but it kind of gives, I think, more of a sense, and an empirical sense, right, of what's actually kind of going on in these interactions and meetings. And just a couple of examples, I'll read these quickly. So the peer specialist shared with patient her lived recovery experience as it related to patient mixed emotions about taking psychotropic medication and the holidays. Peer specialist assisted patient with providing peer advocacy throughout the court proceedings. Peer specialist shared her lived recovery experience as it related to the ability to manage grief and mourning while simultaneously celebrating one's achievements. And I'm not going to read all of these just because of time, but moving down to a second example, peer specialist assisted patient with facilitating artistic creation, inspirational thoughts, meditation and relaxation exercises. Peer specialist and patient mutually self-disclosed in order to discuss recovery as it related to expressing vulnerable emotions when discussing grief and the trauma of cultural racism. Peer specialist shared her recovery narrative as it related to fulfilling a dream to be a successful artist while in recovery, etc. And they go on, and like certainly as you read through them, so that sort of high level overview doesn't really do justice to the depth and the richness here, but in going through and coding them, you really get the sense of a lot is happening here. And there is connection around a lot of different kind of issues that certainly are not captured if we just look at sort of the structured literature on navigator interventions or RAP or bridges. Okay. And then the functions of peer roles. So I'll just summarize them. I think that the slides will go out to everyone. I think people will actually like really get a lot out of actually reading these quotations. I know they're long, but I just didn't want to strip them down too much. But this is just to kind of show some of the variation. So these are different peer specialists all working in coordinated specialty care settings. With activities, this particular person was talking about really doing case management, connecting the youth to Social Security, food stamps, so doing kind of case management stuff, supported education and employment. Other peer specialists we've interviewed are, kind of talking more about groups and kind of more, kind of more one-on-one peer support work. There's kind of a values and perspective taking function. So this peer specialist really describes really not his role directly with the client, but how he is able to sort of reflect back and communicate the client's experiences back to the team in a very different way. So, kind of the examples he gives is like, things might seem like really weird and out there and kind of ununderstandable to the clinicians. And he's like, hey, I actually experienced that too. And it's not that sort of outside the bounds of reason. Here's how to sort of render that understandable. Here's a different way to think about it. So again, really this kind of critical role influencing how the rest of the team is thinking, which is almost completely unmeasured, and unmeasured even when we look at kind of peer support in other settings, like a sort of community treatment. We really don't have a good literature on how the peer specialist is kind of influencing other team members in their thinking, and potentially super important. And then identity and shared experience, and again, just different perspectives on this. So under age, this is a peer specialist who really emphasized, youth, young adulthood. I feel like if I were older in a peer support role, I probably would not have the rapport with our clients that I do. Not saying that we know this is the case. This is something that needs to be much more systematically kind of looked into and understood from the perspectives of both, kind of clients or participants and peer supporters. And then psychosis. So again, this is a longer quote, but this young adult peer specialist really describing how he heavily draws on his own personal experience of psychosis to connect with young people in CSC programs and to give them hope. And throughout his interview, almost every example he gives, he is specifically referencing and drawing on experiences of psychosis. When we look at the field in general, in terms of CSC, a lot of the workforce are peer specialists who don't necessarily have experience of psychosis. So again, that's a question. So age, psychosis, other kinds of identity, LGBTQ, racial ethnic match, I think, again, really important potential sources of shared identity or unshared identity to be looking into. Okay, so that was a little bit of a marathon, but there are at least nine minutes left for discussion. And I think, and a lot of the comments were private, so.
Yeah, I have a number of the questions that came to me, it looks like directly. So, and there might be some that came to you as well here too.
Yeah, well, I'll just do this one quickly, Nick. It's just so somebody who's older working in a CSC program, it's difficult to be a true peer in this role. Have you been running into this trend? But it's tough to find young people in their 20s who are ready to become peers. So from the interviews that I've done with older peer specialists, I have run into quite a few concerns around the challenges of connecting to youth and really being seen as part of a much older generation. Sometimes people have said, though, that then participants are connecting to them more like a kind of a senior mentor figure, or even a parent. Some people have used that analogy. So again, I think lots of questions there, right? How these different things might play out, what the influence is that we need to unpack. And right now, sort of, I think, you see people saying this is really important, or the relationship can play out in a different way. And we don't really kind of know more systematically what the implications are there. And then in terms of finding people in their 20s who are ready to become peers, I think it's really interesting because some programs struggle with this and others don't. I think it's sometimes just kind of developing alternative recruitment strategies. It's how it's advertised, because a lot of young people don't know what a peer support role is. So you might want to put up flyers that have a description rather than that are kind of assuming that somebody would know and be looking for something tagged as a peer specialist. And very often when young adults are hired, they won't yet have certification, in states that require that. And that's just kind of part of the onboarding process, and they get that certification at some point, early on in their employment. So that's a quick response. And then, sorry, Nick, that's any ones that you got, I can.
No, not a problem. If there are others that came directly to you, do you want to just maybe go through those and then we can switch gears to the ones that came to me?
Well, I think they're from the same people. Let me go ahead and ask me one of yours and I will scroll through.
Okay. First question that came in was, On what basis did CMS declare peer support to be an evidence-based practice in 2007?
That's a good question. In the famous CMS director's letter, it is referred to as an evidence-based practice, right? And a lot of people cite that letter. There weren't any references or citations provided. They may have been referring to some of this early work that found no difference between case managers with and without lived experience. And so, so in a sense, that clearly signals that there's nothing detrimental, you know, kind of that hiring as peer specialists leads to. And so again, this is like non-licensed people with lived experience hired into case management roles. So without any other kind of specialized, you know, kind of training, education, licensure kind of thing. So that could be what CMS was referring to. But again, this is part of the fuzziness around, are we saying, you know, the role, specific kinds of activities, like what are we really talking about? Is there such a thing as an evidence-based counselor or a clinical psychologist, or is it that there are clinical psychologists or counselors, let's say, who implement or provide certain evidence-based or evidence-supported services? So I think there's just been a lot of conceptual confusion, lack of clarity about what we're really talking about. And this even plays out in kind of systematic reviews, I think, often. Okay.
Sorry, forgot to unmute there for a sec. Next question that came in is that you noted in the on-track data that people met at least once with a peer specialist. Did those meetings include groups?
So most of the, I think it in the on-track network, I think virtually everybody does groups of some kind, but different, there's different groups. Just from people I've interviewed, people come up with their own, you know, they draw heavily on their own creativity, which is great. You know, in a lot of ways, it's just that sort of that, you know, it very well might be that certain strategies should be more widely implemented, and we really don't know, or kinds of groups. In the California programs I worked with, there were a number of different groups, again, kind of depending on the peer specialist skill set. Art groups, if they were like very crafty, mindfulness groups, if they had a lot of kind of mindfulness and meditation experience.
Okay, next question. In the slide, what's happening in real world CSC? Is the data from the CSC On Demand project or from On Track program?
No, that was all On Track New York, because CSC On Demand is just a training trial. It's just comparing a virtual CSC training for new teams, well, new or teams that haven't had a training in a while, to in-person. So it's not looking at implementation. There's going to be some data from the mental health block grant evaluation that Westat led, and they're working on that now, I believe. So there will be some probably really interesting data, I think, from that project, but it's just, you know, hasn't been put together yet.
All right, next question. Any tips on how to be a translator between the peer and the clinician?
Yeah, so, and actually somebody else, just because I'm looking through the direct questions to me, so very parallel question on that note too. So it's really interesting. One of the things in these interviews that we ask about, and actually there's like a kind of a couple of different interview projects going on, but yeah, kind of across those projects, one thing we ask about is relationships with other members of the team. And that varies a lot. And I'm sure, you know, you could ask the same thing of any team member and you're going to get variation just in group cohesion. And so, and it's really striking how different that is across different programs nationally. So sometimes there are incredibly close relationships, and the peer specialists, that's how they describe their relationship to other team members. They hang out, they go for drinks afterwards, they feel deeply respected. In other cases, you see extreme tensions between other team members or a team leader, or sometimes the prescribers and the peer specialist. And to me, this is a real priority, I think, to do more research on kind of group dynamics and group cohesion in CSC. And especially with these more kind of outlier roles, so supported education and employment and the peer specialists, and where there's a family partner, because I think that prescribers and therapists are pretty, relatively speaking, used to working with each other and have really kind of clear and clearly different roles. But I think throwing all these other roles into the mix can create challenges, or it can go really, really well. And just in terms of that, that translation, I also want to say that I really think that we do put, especially maybe, like young people who don't have accrued years of experience, let's say in advocacy, or maybe higher education, because they haven't gotten through college yet. They're in this peer support role, and we don't have senior leadership involved. We don't have, director level people, supervisors with lived experience. We don't have kind of policy leadership. We don't see, honestly, just in terms of national webinars on early psychosis, many of the technology transfer centers are doing webinars right now. When we look nationally at training teams, it's pretty rare to see the integration of lead trainers, lead designers, co-producers who have lived experience of psychosis. And if they were there sort of modeling that at a higher level, and there were a clear integration in people's minds of like, look, this is how like personal experience of psychosis can really deepen, whether it's policy work, clinical work, quality improvement, redesign, et cetera, right? Sort of seeing that, having those examples, but when it's only this sort of entry-level young adult peer specialist, that places a huge burden on that individual. So I think that that's one way to think about, from a more systems perspective, how we can actually improve implementation at the individual program level, and kind of really like contribute to culture change around valuing what lived experience can kind of bring to the table.
Well, I'm mindful of the time right here. I don't know if there are any questions. Well, I have one more question on my end here, but I don't know if there are any that came directly to you, Dr. Jones, that you want to make sure you want to answer.
Well, there's a bunch, but there's a bunch. So I would just, if people want to email me, I am absolutely happy to answer any further questions. So maybe I can people can follow up with me, or I can follow up with people who emailed me directly, and you can just ask your final question.
That sounds good. So the last question on my end here is there any qualitative data or interviews that you've completed about the need for peers with multiple identities, such as being Latino, trans, and living with psychosis, as an example?
Yes, so there's absolutely peer specialists that we've interviewed, right, who have, in fact, probably most people have at least one additional identity. And then there's an NIMHD R01 that Vicky Ojeda and Todd Gilmer have led, that I'm like a co-I on. So we had two papers come out recently, one on age match and one on ethnic racial match. And they're using very large administrative data sets in California. So there's some, it's very correlational data. We can't make causal inferences, but seem to suggest that there are benefits of especially kind of Hispanic Latinx ethnic match, and then age match above and beyond kind of general, kind of involvement with peer support. Vicky is doing is analyzing focus group data, just focally zeroing in on those issues, as well as, I want to say, in those in that project, there's also questions specific to LGBTQ experiences and sexual health. So and it definitely comes out. I think the challenging thing is that so often there's you're talking to an individual peer specialist, and there's so many things that are kind of unique, idiosyncratic about them. Like they're an incredibly talented artist, and that's part of how they think about their own experiences and how they're connecting with people. Or they're a musician. And so it's, it's hard to kind of pick apart different things. When, kind of asked directly about that, you get a variety of sort of like, this matters, or here's how I use this to connect, or, in one interview, here's why I don't think psychosis matters, because enough of my clients or the participants experience depression and anxiety that I just connect around those things. But then you interview peer specialists with experience of psychosis, and they might say it's absolutely central to their work. So I think it's just going to kind of take some more like kind of dedicated, resources and intentionality in terms of designing research projects to further unpack these questions. But I think some initial evidence actually to suggest that probably a lot of these other aspects of identity and experience do matter, and we're not necessarily paying attention to them in CSC, and maybe should more so.
Great. Well, Dr. Jones, thank you for a wonderful presentation today. I always think when there's more questions than time, that's a sign that, who's ever presenting has hit on a topic that's of real importance here. So I appreciate you taking the time to speak to all our folks here today. And thanks everyone for joining us. Next week, we will have Dr. Melanie Bennett speaking on incorporation of addiction treatment strategies in coordinated specialty care. We hope many of you can join us then. So take care, everyone, and have a good weekend, and hopefully we'll see you next week. Bye-bye.